Good afternoon, everybody. We are here to discuss about the new rheumatology curriculum. Just waiting for the presentation to be uploaded with Wiki on. Otherwise, I'll try and share the presentation from my end. Yes, Wiki. Thank you. So all of you are familiar with the new rheumatology curriculum, which is going to be implemented from August 2022. And some housekeeping things. The event is going to be recorded, as you're all aware, and people who can't make it today or you want to sort of re-access it, it'll be available on the JRCPTP website. We'll also talk to the BSR and get it available on the BSR website as well. Please keep your camera off and mute your microphone and use the chat function, as Anne Scott Russell has already mentioned, to ask questions. And we will have two parts to the questions. After the first three presentations, we will try and sort of have a short break and discuss questions with the internal medicine flavor. Next slide, please. So that's the plan for the day. I'll do the introduction, followed by internal medicine requirements from Phil Bright from HEE. And Ian Goff will talk about the changes to the rheumatology training and implementing the new curriculum. And we'll have a break for discussing the internal medicine issues. We then move on to the transition of current trainees and e-portfolio developments from Wiki Ong. And we'll have a recorded presentation from our trainee perspective from Anastasia. And then there'll be a role play video between a trainer and trainee, Anne Scott Russell and Emily Rose. And we'll have the part two of the questions from the rest of the panel members. Next slide, please. Okay. I'm the co-chair for the Rheumatology SAC, and I've been involved in developing the curriculum, and I've been supported by our curriculum lead James and Anne Scott Russell and other members of the SAC, and our lay reps and trainee reps over the years. I want to try and thank everyone for supporting this long drawn process. But I think to try and highlight the generic changes to all the curricula. There are different from the old curriculum, which was sort of developed in 2010. It's about 12 years now. There are a smaller number of high-level learning outcomes rather than a multiple tick box exercise of a large number of competencies. And there is holistic assessment of progression of trainees and expert judgment from the educational supervisor, saying that a trainee can be entrusted to do a particular activity or has got a particular capability. There's a progression grid which will set out the expected level of supervision required at the end of each training year. It'll be like level 2, 3, or 4, and everybody's expected to be independent or level 4 by the time they attain CCT. And the generic and the specialty SIPs. SIPs is a short form for the capabilities in practice, as it does not easily roll out of your tongue. They map to the GMC's generic professional capabilities. It's one of the requirements of all the curricula. In internal medicine, the curricula have been built as stage 1 training, a 3-year program from IMT1 to IMT3, preparing the trainee for the medical registrar role. And they do that in the IMT3 year. Internal medicine capabilities are all included in all the group 1 specialty curricula, and rheumatology is one of the group 1 specialties. There's an indicative 12 months of internal medicine, stage 2, integrated flexibly with specialty training in a dual program. And these 12 months can be spread out in different ways. We will discuss that later. And this model enhances generalist training to prepare doctors who can manage acutely unwell patients with complex presentations based around chronic disease and comorbidities. This depends on our demographics. Next slide, please. What's not changed? People, whenever there's change, there's always resistance, but good supervisory practice is essential for this to succeed. There's still the ARCP process, and we still have supervised learning events and workplace-based assessments, but they're not numerous to try and have a tick box. So what is a SIP, or capabilities in practice, and where does this come from? They describe the professional tasks or work within the scope of a curriculum. They're based on the format of entrustable professional activities. which is borrowed from North America. And they also have in Australia and New Zealand these entrustable professional activities where they sign off a trainee saying that they're capable of running an inpatient take or unselected take, or they can manage an outpatient or day unit. They utilize professional judgment of appropriately trained expert assessors. That's your supervisors, both clinical as well as educational. And they provide a good way of defensible way of forming global judgments of what somebody's professional performance. And to complete training, as mentioned before, a doctor should demonstrate that they are capable of unsupervised practice, that is level 4 of entrustment in all the SIPs as detailed in the curriculum. So each SIP is further broken down into descriptors, what is the expected level of performance, and how a SIP is mapped to the relevant GPC, generic professional capabilities. We could see some illustrations from the internal medicine curriculum and as well as the rheumatology curriculum. And this evidence is used to inform entrustment decisions. Slide, please. Each SIP is a set of descriptors associated with that activity or task, and they indicate a minimum level of knowledge, skills, and attitudes which should be demonstrated. They're not a comprehensive list, and there are many more examples that could provide equally valid evidence of performance. Next slide, please. Here's an example of a SIP 4 from the internal medicine curriculum, stage 2. So it's managing patients in an outpatient clinic or ambulatory community setting. So demonstrating professional behavior with regard to patients, carers, and others involved, delivering patient-centered care, including shared decision-making, demonstrating effective consultation skills, formulating an appropriate diagnostic and management plan, taking patient preferences into account, explaining the clinical reasoning behind your diagnostic or clinical management decision to the patients, carers, as well as colleagues, and appropriately managing comorbidities in different settings, and demonstrating awareness of the quality of patient experience. This describes what is expected. And the SIPs are grouped into 3 categories: generic SIPs, internal medicine SIPs, and the specialty SIPs, and in our case, it's rheumatology. The generic SIPs cover the universal requirements. It covers the universal requirement of all specialties as described in the good medical practice and your GPCs. Internal medicine SIPs cover the clinical tasks and activities essential to the practice of internal medicine, and the specialty SIPs, like rheumatology SIPs, cover the practice of rheumatology. The generic SIPs, we've got 6 of them. So this is common to the old curriculum, where we had some of these generic functions, and people are familiar with that in the e-portfolio. Ability to successfully function within the NHS organizational management system, dealing with ethical and legal issues, communicating effectively, focusing on patient safety and quality improvement, carrying out research and managing data appropriately, and acting as a clinical teacher and clinical supervisor. This is generic to all specialties, so to try and comment both internal medicine as well as the specialties. Next one, please. Example of a generic SIP. It's on organizational management system within the NHS, adhering to your GMC requirements, public health issues, which you're well aware with the COVID, effective clinical leadership, open and transparent culture, keeping up to date, learning and through learning and teachings, the CMEs or CPD, engagement in career planning, capabilities in dealing with complexity and uncertainty, and role and process for commissioning awareness, and awareness that need to use resources wisely, which is essential with all the pressures we have now and the economic crisis we find ourselves. Next slide, please. This is an example of a generic SIP. Continuate with it maps to the domain 1, 3, and 9 of our GPC from the GMC. So professional knowledge, professional values and behaviors, and research. What is the evidence which will inform the decision? A multiple consultant report, not one person, but a group of people, 3 or 4 consultants commenting on the trainee's performance, a multi-source feedback, which is useful from the whole team, evidence of active role in governance structures, attending your governance meetings and taking part in the governance, attending a management course, and end of placement reports. All these things could be evidence for the generic SIP. This is just an example, and we've got the remaining 6. Then we've got 8 clinical SIPs for internal medicine, managing an acute unselected take, acute care of patients, providing continuity of care, managing patients in an outpatient clinic, problems in other specialties, liaising with them, and the multidisciplinary team, effective discharge planning, effective resuscitation, and managing acutely deteriorating patients, and managing end of life and applying palliative care skills. Next slide, please. This is an example of a IM SIP, managing an acute unselected take, which the descriptors there. Next slide, please. And this maps to all the domains of the GPC, all the 6 domains. And the evidence is for the unselected take from the MCR, MSF, case-based discussion, acute care assessment tool, a logbook, and simulation training with assessment. Next slide, please. The specialty-specific SIPs will be sort of dealt with in the presentation by Ian, but I think we've got 7. We have to condense the old curriculum into 7 SIPs. Managing common rheumatological disorders across multiple care settings, managing rheumatological emergencies, which even elaborate, managing complex rheumatological disorders across multiple care settings, like connective tissue diseases. Then the separate SIP on managing transitional care, chronic pain, metabolic bone disease, and rare rheumatological disorders. Competence and practical procedures is a separate SIP, which will be highlighted by in our trainee perspective. Managing and leading an MDT and coordination of care with other specialties like orthopedics, critical care, respiratory or renal. And we also added a SIP of interaction with primary care and demonstrating effective relationship with primary care teams, patients, and patient groups. Next slide, please. Then we have our syllabus, which is our presentations and conditions, which is not elaborate. So this will give you the monoarthritis or polyarthritis, CTDs, and this thing, a list of conditions. So that is in the curriculum, and you can look at the JRCPTB website for that. But the patient is always at the center of knowledge, learning, and care. And the trainees are expanding the knowledge, skills, and attitudes around managing patients with these conditions and presentations. Okay, next slide, please. The new rheumatology curriculum is an exciting opportunity to support the training of new generation of rheumatologists. We acknowledge all contributors, as I mentioned earlier, all the rheumatology SAC members, the curriculum subcommittee. Trainees have been involved in the development of this curriculum, lay reps to give their perspective, and the JRCPTB admin team. And please refer to the frequent ask questions under the curriculum. Thank you. I'll invite Phil Bright from HEE for the next session. Thank you.
Sorry, I'm assuming, can you not see my screen anymore?
No, I can't see your screen.
Okay, I'll try sharing again. 1 second.
Yeah, thank you. In the presentation mode, please, Vicky. I think people can add questions on the chat as we speak. Thank you. Over to you, Phil. Just waiting for Phil
Vicky,
Bright
if
to speak.
Phil's dropped out.
Whilst
Be
sharing
there.
my screen, I can't see Phil.
We'll try and
unfortunately.
have a look at that. I'll try and have a look at that because he was there at the beginning.
Yeah.
Okay. Unless his connection is sort of gone off. So Phil Bright is our head of School of Medicine in West Midlands, and he's our lead dean's representative in the rheumatology SAC. And he sort of plays major role in the sort of in the internal medicine level in recruitment as well as changes. He will join us shortly. And if there's any problem, then we could sort of move on to.
Do you want me to?
Ian, if you
Should we
could
move
sort
on
of
to
do
my
that.
bit?
Yeah, if you could move on to
I will.
Vicky, if you
slides
move
further.
on to the
Yeah.
the changes to specialty, that'd be great.
It's easier than stopping my sharing screen mode.
That's right.
Okay.
Yep. Ian now. Ian is my chair.
Thanks.
Thank you, Ian.
Thanks. Yeah, I'm Ian Goff. I'm a co-chair of the Rheumatology SAC with Venkat, and I'm a rheumatologist in the northeast of England. I'm going to talk a bit about the changes to specialty training, and I noticed a question popping up: how will it practically change what you do day to day? So we'll cover a bit of that, but can also cover that in questions. I guess the key headline changes are that this is a focus on acquiring more generalist skills earlier on in training, so that when people do end up in specialist training, they have a broader generalist background and base, and they've already acquired some of the general SIPs. The change in assessment is very much towards a high level assessment of SIPs, holistic decisions, rather than what can and has in the past been something of a tick box exercise into making sure people have got the right number of DOPs and KECs and CBDs. We want to move away from that and think much more about, can people be entrusted to do an outpatient clinic or a ward round or that kind of thing. We have moved, like Venkat has mentioned, to include multiple care settings and kind of leading teams in our SIPs, and there is also a move towards keeping general medicine skills up to speed throughout training. So keeping in touch with general medicine. It has in the past been fairly common for people to do a lot of general medicine early on and then nothing for several years. And then the final bit that's been added in really is experience in other specialties, and that cross-pollination that comes with experiencing different specialties and bringing our skills to them and their skills to us. Next slide, please. So what the new curriculum is not is a smaller or reduced curriculum. So Venkat and the curriculum leads have been at pains to transfer across much of the old curriculum and translate it into SIPs. And it is not a shorter or condensed training program, albeit we have front loaded the general medicine. Next slide, please. So the specialty specific SIPs, Venkat has already outlined. We have 7 of them, and they cover the majority of things that we always have covered. So the emergencies, the common stuff, but also quite specifically and explicitly how people lead and manage teams, because we're a very multidisciplinary specialty, and also how we interface with primary care and other specialties. We're not going to go into each one in detail, but if we move on to the next slide, there are just examples of some of the SIPs in rheumatology. So SIP 2, managing rheumatological emergencies, is many of those skills are demonstrated in the general SIPs, but the accurate diagnosis, the knowledge, that kind of thing, recognition of rheumatological disease is specific to our curriculum. Next slide, please. Like Venkat had mentioned, we're not doing away with CBDs and KECs and DOPs, but the focus of how they're used is changing. So as educational and clinical supervisors, we'll no longer be counting DOPs and KECs, but using them as pieces of evidence with which to make a holistic decision. So we'll still be using all the old tools and more. And if you move on to the next slide. So along with the old, all right, move. So this example, so SIP7 interface across primary and secondary care, different bits of evidence to inform that, MSFs and reflective practice, but still tools that we've used over a period of time. Next slide, please. So as I'm sure Phil will allude to later on, these bits of evidence and SIPs are assessed and allow us to make an entrustment decision for postgraduate doctors. And the expectation is that people will progress through the period of time that they're training, so that when they start out, they're at level 2-ish, and that by the time they are ST7, they are entrusted to act unsupervised. And that's always been the case, but it's explicitly set out now in the curriculum. Next slide, please. And this is the grid that Venkat alluded to earlier. So we'll be using this when we're doing ARCP to just guide whether or not people are progressing at the rate that we expect them to, and acquiring the competencies we want them to. So things like emergencies, we will want people to be able to deal competently with emergencies fairly early on, but the more complex stuff doesn't come until later. Next slide, please. So along with the old tools, there are a few new developments. So the first of which is the Acat. So many people are familiar with the Acat for acute care assessment on ward rounds. Well, this has been developed to do something similar with a whole outpatient clinic. And as it's such a huge part of our clinical work, the Acat is a useful tool to be able to feed back on how a postgraduate doctor is managing a clinic, the entire job of the clinic. Next slide, please. The other bit that is new with this curriculum is the requirement for a self-assessment. So trainees at the end of the year will make a self-assessment of their progression against each SIP and record it on the portfolio and link it to the evidence they feel illustrates this. And that then allows us, if you move on to the next slide, please, allows us to make that holistic decision, taking in the trainee performance, professional examinations where applicable. So for us, that's the knowledge test, workplace-based assessments, supervisor feedback, and then the trainee self-assessment. So the hope is that whilst it is a move towards more of a kind of apprenticeship style and more of a focus on ES and CS reports, we're still using good evidence to inform that. As ever, this hasn't been an easy process. There's been lots of debate among the SAC and conflict about the balance between medicine and specialty, between training and service, and the notable omission that many people will and have pointed out is we have not added in ultrasound to the curriculum. That's been long discussed, but it is known, and it's because of the need to be able to fit everything in, train people to a level of competence where they are independent, but without extending training. Next slide, please. So in terms of practicalities and how we integrate the two CCTs, the timings and numbers are indicative, but things that we do anticipate. Trainees, postgraduate doctors will be involved in acute unselected take in each of their years of training. And that is explicitly stated now and is intentional to keep up those skills of general medicine and not let them degrade. And that's, you know, indicative of about 1 per month, but it's not a hard, rigid number. There is a recommendation of 12 months across the period of training for continuing ward care. Now, in rheumatology, there are very few new units that have a ward anymore. So this is going to have to be negotiated locally and is being negotiated by TBDs locally as we speak. But it won't be a standard and it won't be the same in every region. So I know in the Northeast, we are planning for everywhere to do 3 months in each year, but other regions may well do 6 months in the first year of ward-based care and 6 months in the last. Either way, there will be local agreement and we need some flexibility. And the last bit that is new is the clinics, the requirement for some clinical experience in non-parent specialty. So outpatient clinics in another specialty, doesn't have to be a single specialty, it can be several, but that allows that cross fertilization of ideas. Next slide, please. So the key to remember, and we've discussed it at length in various fora, is that this remains a competency-based curriculum. So if people are progressing at a faster rate, we've always had the opportunity to move CCT dates. This is very much around, you know, assessing whether someone is capable of doing certain tasks. For people who are transitioning from one curriculum to another, the gap analysis will be absolutely crucial in identifying the needs and the things that need to be kind of added on and the gaps that need to be filled in. Vicky's going to say more about that a bit later on, though. Next slide, please. So I guess tips for kind of implementation, similar to the recommendations for IM1 and 2, planning the training year early with your ES and CS is really going to be important, so that at each meeting you agree how each SIP might be demonstrated, and starting to plan ahead for DOPS and KEX, rather than what it has traditionally been is a rush towards the end of the year to get assessments done. We know that it is likely to take longer to do ES and CS reports. They're going to need to be balanced, thought through, and are likely to be more detailed. But there is going to be support and training and guidance on how to fill these in. And finally, I think we do need a healthy dose of pragmatism during the transition period. We do want to get away from kind of slavishly adhering to, if I'm one outpatient clinic short, will I not be able to pass my ARCP? These are holistic assessments of how someone is doing. So we will be moving away from that kind of rigid, you haven't got enough of X, so you can't pass. Next slide, please. So further information, there's a number of bits that are both published already and are in process. So there's a rough guide that is going to be published on the PTB website, and a number of other bits and bobs of information. If you go to the next slide, there are links in this presentation to a whole number of supporting documents, including the e-learning for health training modules that are really good at giving tips on how to train and what the new curriculum will look like. I think Phil is back by the looks of it, so we can probably, Vicky, go back to his bit.
Yeah, I'm just going to stop presenting because I think Phil has sent me some different slides. So I will stop sharing my screen for a moment and download those if you want to chat around that for a second.
Thank you. The apologies for that. It seemed to be a problem with one of the slides, so we've just reformatted them so that they are less troublesome. I'm Dr. Phil Bright. I'm Head of School of Medicine in the West Midlands and also the Health Education England Clinical Advisor for Internal Medicine Training. Undertaking the change in the curricula that we're about to undertake, if anyone thinks it's easy, they probably haven't actually understood the magnitude or the depth of the change that we are currently trying to engineer. So if we can go to the second slide.
Sorry, it's just being a little slow. There we go. Is that presenting okay?
It was still on the first, but
if you can go in the presentation mode, so it should sort of start moving.
Yeah, that's what it's showing on my screen. So I've got in front of me a view from America. No.
No.
Okay.
You need to go to slide 2, please.
Okay.
I'm moving them and they're not doing anything.
Okay. Sometimes I think when you share the presentation, sometimes it doesn't sort of work out.
Stop and try again. Maybe that will.
Okay. Okay. I think while we're waiting for that in this thing, and I think we can try and do this flexibly. I think, do you want to go back to the old beginning of the presentation, which we had? That might be useful, that you had the slides. That might work well.
It's
the one you shared.
Frustratingly sharing on my script. This is the old
That's
slides,
okay.
unfortunately.
That's fine. If you just, that's fine. If you just go back to the beginning of this will work, Vicky. Because we've got all the slides in this thing there.
Sorry.
That's okay.
Back to Phil's. I'm trying to.
Yeah, if you can go back into that.
See this, yes.
That's right. Why a change? Yeah.
Here,
okay.
Is that okay?
Right. Thank you.
That's it. So we know from some very careful modelling that the UK demographics is about to change, is changing very dramatically. We're going to be looking after an older, not necessarily frail population. So they sit outside of that normally looked after by geriatric medicine. And that therefore means we need practitioners with a different skill set to that which we've had in the past. For the last 20, 30 years, UK physician practice has been specialty first to a very large extent, but the population that we are now facing is of both older and younger patients with complexity, with multiple, not necessarily etiologically related comorbidities. And at a time when healthcare resources are probably going to get tighter, if we take an example of a 55-year-old lady referred to the cardiologist with shortness of breath, I'd just like to count the number of specialties in this tale. So cardiology, 1. Found to have multiple PEs, referred on to respiratory, 2. Also had a cough, which was thought to be due to gastroesophageal reflux disease, so was sent on to gastroenterology, 3. had some mobility problems, so was sent on to neurology because I thought to be neurologically based 4. Someone then said, well, what's the cause of the PEs and the neurology? Could it be rheumatological? Sent on to rheumatology 5. So you have this 55-year-old lady who very quickly accumulated 5 sets of outpatients, each of which was doing its own tests, each of which was writing back to the GP, who was meant to be orchestrating the care of the patient. And the poor GP was, of course, completely and utterly out of their depth. And that is going to become increasingly the type of patients that we're going to be challenged to look after. If we take an international comparison, next slide, please. In the United States, they approached this 20 years ago. Can we have the next slide up, please? And they brought about something called the Hospice Movement. So if any of you watch American TV, you will have seen a dramatized version of this in the series called House, where they have recognized that having a specialty first healthcare delivery isn't the right way to go. And what you need are people who have good general internal medicine skills. I won't leave that up for long enough for you to read the whole thing, but we now need to go down this path, and that's what the Shape of Training report published at the beginning of the 2020s defined for us. Next slide, please. So we have to now deliver over a shorter training time both the specialty training and the general internal medicine training. So when we talk about a trainee, they're not rheumatology trainees or cardiology trainees. They are GIM and rheumatology, or rheumatology and GIM. Both curricula have the same standing. They're going to get 2 CCTs at the end of this, and for which they must be properly assessed against 2 curricula. It's also worth noting that GIM is not just the acute unselected take. GIM is the acute unselected take plus the post-acute care of patients and the outpatient care of patients. Both curricula are equally important. Next slide, please. Some specialties would say, well, yeah, our trainees get GIM in specialty. But what they're getting is the GIM version, sorry, the specialty version of GIM. My cardiology colleagues are notorious at saying this. Why should the trainee have to go and get GIM experience in another specialty? We have GIM patients on our ward. Yes, you do, but you look after them as a cardiologist. And part of the skill set we need is for our future consultants to know how to look after the bread and butter cases, clinical scenarios in complex patients, but also know what their limits are and when to call in the specialists for more specific care. So if you go back to that example patient I mentioned earlier on, each specialty was doing its own thing and wasn't actually thinking, well, I could treat the PE, I could do that bit, but no, they referred on to another specialty. And in defining the experience we need for our trainees, the curricula set down minimum numbers, indicative numbers, but it's not about hitting the minimum. It's not about being adequate and producing adequate trainees. It's about producing best possible trainees, and that might mean a bit of give and take and actually exceeding the numbers where the individual trainee needs to exceed those numbers to become best possible and not just adequate. It's all dependent on the needs of the individual trainee. Next slide, please. So this is what the curriculum says, as Ian has just said, 20 outpatients in another specialty. There are the final year requirements. Either they have to do a month of focused acute medicine or 3 months of general internal medicine, less focused. and general internal medicine has to be over, they have to do an indicative year, but it's that word indicative again. That's adequate. It's not best. Next slide, please. We also have to think about the supervisor training. So the traditional model is that the specialty supervisor and the GIM supervisor are one and the same individual. Does that model work? Ideally, they should be two separate individuals with two different focuses. Logistically, not practical. In rheumatology, where many rheumatologists don't practice GIM, then you certainly have to be skilled up in the GIM curriculum. Ideally, you'll be practicing acute unselected take. So perhaps in rheumatology and some of the other group 1 specialties, you do need the two separate supervisor models. We need to make sure that the supervisors actually have the right capabilities themselves to do the job. And what we're looking for is separate GIM induction, separately documented, separate monthly education meetings at which that initial year strategy plan is reviewed and updated and the evidence is looked at and the trainees supported and the reflections are read and that they're given encouragement to reflect better and advised as to what evidence they should be gathering. There has to be separate GIM evidence to specialty evidence. So separate multi-consultant reports, and there has to be a separate considered thoughtful end of year educational supervisor report. And as we've just seen, the style of supervision has to change. It has to become a much more dynamic, much more holistic supervision model. And that in itself, particularly at a time of service recovery, is going to be a real challenge to deliver. Next slide, please. We can about the ARCPs, and again, for face validity, you can argue that there should be separate ARCPs for specialty and for GIM. Logistically, that is an enormous challenge. So we have three ways of approaching this. Either you do have separate ARCPs, you have combined ARCPs, but there the problem of demonstrating face validity comes in, or you can have separate for some years, combined for other years. In the West Midlands, we're trying to go for combined for the first years, but then in the final year have separate. And remember that the two CCT dates must align. And that's going to produce problems when trainees apply for OOP, because both the specialty SAC and the GIM SAC will have to agree as to how much time, if any, a particular experience, particular OOP, will count against each program. And you have to try and keep the CCT dates aligned, so it's going to become complex. Trainees must have an ARCP outcome against both programs in every year of the program. Next slide, please. How do you then make it work for rheumatology? You have to work with your local GIM TPDs. Those conversations now should be fairly deep and fairly frequent as to how this is going to work from the start of the new academic year. It's going to be challenging, yes, but you can also make it work for the specialty. If you make, for instance, the GIM experience complementary to the rheumatology experience, then that's going to work for both curricula, not just for one or other of them. And at that point, I'll stop. Thank you.
Thank you very much, Phil. And I think we pause for questions. We've got a few questions on the chat. And I will request sort of Anne, who's been monitoring our chat, to try and see any questions with IM flavor, because we've got two more talks and a video presentation on role play.
Yes. So we've got a couple of questions on the chat, Phil, about IMT issues. They're both regarding the sort of practicalities of making the rotation more integrated with the IMT and rheumatology side by side. The first one is how can the acute take be achieved if there's just 6 months medicine required in ST4 and 6 months required in ST7. How can the continuity be achieved in the intervening years?
So for the acute unselected take, trainees are also expected to engage with the acute unselected take on a monthly basis, minimum monthly basis across the entire of their training program. The only exception to that is where there is a specialty on call as a curriculum requirement, not just a service requirement, but as a curriculum requirement, in which case for that period of time, the trainee can be excused the acute unselected take and can do the specialty take.
Yeah. So where we're talking about the 6-month periods, that's really for ongoing inpatient care, isn't it? Not for the acute takes, which should be continuing throughout. And then there's a second question from Jenny Nixon, who says, for 12 months continuous ward cover in 4 years, would a GIM ward cover at ward round once a week for a year count? Or do we need to do these things in a block or a full ward cover for a month or more at a time?
So think about what you're trying to achieve for the trainee, and then think about whether the experience you're providing can achieve that for them. So let's think about the doing a GIM ward round. Are they really gaining management experience by attending, perhaps with a degree of disinterest, a ward round? It won't be GIM because they don't exist at the moment. It'll be a ward round led by a cardiologist, a respiratory physician, somebody else. Is that going to be giving them the right kind of management experience, or would they develop better if they are effectively operating as the maybe junior registrar on the ward and making day-to-day decisions? It's about what you want the trainee to have developed. I would say that a deeper embedded experience is better, and it should include the weekly ward round. When you're in that experience, it doesn't mean you can't still do a rheumatology clinic, but you'd want to keep those to a limit. So go for best experience, not just adequate experience.
Yeah, thank you. And then just aligning to what you were saying about having a specialty on call, and that being maybe a year when you didn't need to do the acute medicine. It's there's a question. We have 1 year of pure rheumatology with specialty on call. Will that work for the? How will that work for the GIM ARCP that year?
So first of all, is it curriculum mandated? If it's not curriculum mandated, it's going to be difficult to justify. If it is curriculum mandated, I don't think it is it a whole year? When you're doing that, it doesn't necessarily mean that you only do specialty on call. You could do a mixture of specialty on call and general internal medicine on call, as long as you don't breach the junior doctor contract maximum limits.
Okay. And then with regards to CCT dates aligning, what happens for those trainees who are currently out of programme, who have had some time counted for rheumatology but not GIM? So presumably they're coming back to the new curriculum.
So they have to come back to the new combined curriculum unless they're in their final year so it'd be between August 22 and August 23. Their CCT cannot be awarded until both CCTs are awarded. So if their GIM CCT cannot be awarded, even though they've effectively got an outcome 6 from rheumatology, they can't get the CCT until they get an outcome 6 in both.
Yeah, okay. And then more questions around how to incorporate the acute take into a rheumatology pure year. That I guess involves discussions locally with your hospital and with your GIM TPD, doesn't it?
And the argument you don't want to get into, because you can't win it, is if the trusts say, we want them to do this amount of service, they hold their employment contract. And as long as doing that doesn't prevent them from meeting curriculum requirements, the trust has the whip hand there.
I think this question here is about academic trainees being expected to do GIM, rheumatology and academia. That's the case, isn't it?
Yeah, and that's a real challenge, because for ACLs who are expected to do 50% of academic time, I think it is going to be virtually impossible virtually impossible for them to do essentially 3 CCTs in the time. And I think there's a certain inevitability. It's not absolutely inevitable, but you can see the push towards their CCT date being moved backwards.
Yeah. And then another question about what examples will constitute once a month acute unselected take? An alternative might be to work on the acute medical unit as well. Is that not right, Phil?
I would say the acute medical unit is the equivalent of being the acute unselected take. I wouldn't differentiate between them. If you're on the acute medical unit, you're going to be seeing fresh patients come in. They may not be still in their outdoor clothes, but they're going to be, they'll still be wearing their socks.
Yeah. Another question, less than 20% of consultant rheumatologists practice GIM. Are we going to need a whole load of extra GIM educational supervisors? I guess the answer is yes.
Yeah, and this is a conversation with the local GIM TPD. In the West Midlands, we're about to start a trial of remote supervision. And actually, we're going to try and do it in rheumatology, although I'm not quite sure I've spoken to the Rheumatology TPD about this yet. So if he's on the call, I apologise. If he's not on the call, don't mention it to him until I have. The idea is that we will identify a couple of people who will do remote educational supervision, i.e. over Teams, for all of the rheumatology trainees that need it. Because of this challenge of your rheumatologists feeling a little bit uncomfortable supervising the GIM component of their trainees' training. We don't know how it's going to work. But what we're trying to do is to work up the principle. Around about 2024, there'll be about a 20-25% uplift in HE trainees as the medical school bulge works through the system. So that will be hitting high specialty training around 26-27. There's 2 challenges here. There's the training experiential capacity and there's the training supervision capacity, and it's the latter that we're going to be really short of, because you won't get the new supervisors until these people have gone through. So it's chicken and egg. So you've got to come up with an alternative supervision capacity plan.
And a question from a trainee: what happens if you're in your final year in this coming October or August? Is there still an expectation to do acute unselected take if you've already done so every single other year? I'm guessing they're still on the old curriculum, aren't they? Because you don't have to transfer if you're still in your final year.
Yeah, if you're in your final year, you won't have to transfer, and therefore I think not. I hope I'm not misunderstanding the point.
Yeah. Will trainees who are out of programme after ST6 at the time of implementation enter ST7 on the old or the new curriculums? That's the same issue.
I think we are going to discuss about transition shortly. I think we will try and sort of do that. Okay.
Yep. There's quite a few other questions here, actually.
Some regions are mentioning and is about this intensive specialty on call, which is like there's an exemption for a year in cardiology, or if you're doing stroke medicine or GU medicine or something like that. So I think rheumatological emergencies is one of our SIPs in rheumatology. And I think in some regions, the rheumatology on call has been dispensed with, and people can acquire the rheumatologic emergency capability during 9 to 5 by seeing sort of acute referrals in the ward or EMU or the SDEX and things now. But I think if there are intensive specialty on calls in some regions, so I think they can possibly negotiate the GIM bit on that period, because they can't be in 2 places. And I think if the on call is going to collapse and this thing, but I think we need to review that.
It does depend. Sorry, it does depend on whether it's a curriculum requirement or a service requirement. Sure. Certainly in some specialties, they've become dependent on trainees delivering specialty on call because they don't want their consultant staff to do it. Well, there has to be some give and take there. What is the learning from doing the specialty on call? And if that then means that other bits of the curriculum cannot be delivered, then there is the curriculum takes precedent. But if it can be delivered because the service needs it and it doesn't interfere with curriculum delivery, then the service takes precedent.
Fair enough. There's questions about the curriculum, and all of the information about the exact requirements for GIM are on the JRC PTB website, aren't they?
Yeah.
somebody's asked, how is the training outcome different compared to the old-fashioned dual accreditation in rheumatology and GIM?
So it's about how the decision to say whether somebody has met the curriculum requirements is made. So it's a much more holistic, guided approach. What we are looking for is for supervisor and supervisee to almost become married for a year. Perhaps that's not the right analogy, but to have a very close relationship over the year where they really work together. And at the end of it, through a series of conversations, guided meetings, and evidence development, a report which actually quotes the evidence. So a report that just ticks the boxes saying, yes, you're at this level, tick, is not acceptable. It has to say you're at this level, tick, because here is the evidence, and there has to be a narration for that. And that should help us develop better general physicians as well as better rheumatologists.
Brilliant. And that leads on just to our final question, which is quite pertinent. How much more will you be asking time-wise of educational supervisors? We're already struggling to recruit them.
So under the current contract, it's an hour per week. Now, I'm well aware that that is fantasy time and that hour is used for other things. So what we're asking is that that hour is actually properly dedicated to being educational supervisor. So if we're saying a monthly meeting, that's only using 1 of 4 hours per month for which people at 0.25 are being paid. I think there is a challenge around if you have 2 supervisors in the system, should both get 0.25, and I think that is a really important argument that we need to be having with HE and trusts. The standard HE position is, oh, well, we already give trusts so much money. Not sure that's going to cut the mustard here, but it is to properly utilise that time which should be in job plans and to make sure it is in job plans where possible. I think we need to think about moving to people who supervise just one programme rather than foundation and core and specialty. But that is perhaps a longer term ambition.
Brilliant. So I think the rest of the questions can wait until the end of the second part, but thank you very much, Phil.
Thank you, Phil. Thanks for your contribution. And I think we move on to Wiki's presentation on ePortfolio and transition, please. Wiki, I'm happy to move your slides.
Yeah, I think I've just about got them.
Okay.
Up.
If you're happy.
Oh, no.
Thank you.
Not that bit.
Okay.
Bear with me, sorry.
Do you want me to share them? Do you want me to share them?
I think I've got them open, sorry. So just here we go. There.
Well, we'll give time for those to think about the questions. Here we are. So Wiki is a curriculum and assessment officer in GRCPTB, and she's been instrumental in supporting us getting the curriculum through the GMC with Zoe Fleet and the team. And she's going to talk about the changes in ePortfolio and transition, which many trainees are concerned about. Thank you.
Okay, so I'll just give a quick overview of the developments we're making primarily to the ePortfolio to support this move in Curricula. And of course, now the slides are not moving forward. Here we go. So here we've listed the changes that we're making to the ePortfolio. The ePortfolio will be the same ePortfolio that you're already using and familiar with. So primarily, the first job we're doing is putting the new 2022 curricula up onto the ePortfolio. There will be a new specialty-specific educational supervisors report, a specialty-specific multiple consultant report, and a summary of progression page, which your supervisor and trainee will be able to see every year as to how you're making progress against the targets for that year. And for those specialties where there are specialty-specific assessment forms, we are also updating those. This is an example of the geriatric medicine one, which is already loaded up onto the website. But as you know, the new curricula are SIPs based, and the SIPs will be grouped and appear on the curriculum page on the portfolio. So there's a folder for the generics, the internal medicine ones, specialty specific SIPs, and a folder for the practical procedures. And you'll be able to access all of those where you can record your evidence. As I said, there's going to be a new educational supervisor report. This will be designed for each specialty and will incorporate the generic and specialty SIPs. And there will be a separate educational supervisors report for the internal medicine. This report will auto-populate the ratings and comments made by the educational supervisor taken from the curriculum page. And educational supervisors must ensure that they update the curriculum with the latest ratings and comments for each SIP prior to creating the report. Also be a new multiple consultant report, and again that's going to be designed for each specialty, will be specific and will have the generic, internal medicine and the specialty SIPs. This will be completed by consultants or associate specialists, other doctors who are able to provide feedback on the trainee's clinical performance. And all the MCRs will be collated and summarised each year in a summary sheet. A new area that's been designed is a summary of progression, where you will be able to see how a trainee is progressing. And it's going to be, again, designed for each specialty, will be specific and will provide an overview of all the evidence recorded in the e-portfolio to make it easier for both the trainee and the educational supervisor. It'll be organised in the sections that reflect the ARCP decision aid, and that will be available on the website in the rough guide, so it's easily accessible for everyone. And it will auto-populate, so there'll be no extra work for the supervisor or the trainee to do, and it will display the latest data. And that is to be used for meetings between the supervisor and trainee, and can be used for ARCPs as well. Whilst that's probably very difficult to see, but we'll be able to circulate the slides. After that is each area, so that says this will be the summary page. It'll have your educational supervisor report, the SIPs, but as I say, each section will auto-populate data if there's any evidence recorded against that in the portfolio. If there's been a specific target, it will be marked green. So for example, if you've reached SIP level 3 on SIP 1, that will be green, and then that will just stay that way. So the timeline for the changes, all the curricula are ready and will be on the e-portfolio for this August for those starting on the new curricula or transferring. The multiple consultant report, we aim for that to also be ready for August new starters. The educational supervisors report we plan to have prepared for Q4, Q1 next year, but in plenty of time before any ARCPs. And the summary of progression page will be ready for 2023. And then I think the area that causes a lot of concern is that of transition of current trainees to the new curricula. And there's lots of guidance on the PTB website, but that guidance is based on the GMC requirements. And the GMC's policy statement is that the transition of new learners to a new curriculum sets out the requirements for doctors in training to move to the most recently approved curricula and programme of assessment. This is in the interest of patient safety, maintaining educational quality, and that doctors should be trained and assessed against the most recent standards for that specialty. So they say that doctors in training should move to the most recent GMC approved curricula as soon as feasibly possible. But however, there is flexibility built into that system. And that's doctors in their final year of training, and that is pro rata for those less than full time, are not required to transfer. Some cohorts of trainees may experience a greater impact than others and require longer to prepare for the transition. And if it would not be in the interest of patient safety or would be impractical to support a move to a new curriculum, a trainee may remain on the previous curriculum. So the principles for transferring to the new curricula. As I've said, most trainees will move to a new curricula. It is intended that all except those in their final year. It is recommended that trainees transfer at the start of the training year. And then the flexibility I mentioned earlier, if someone is not going to move, the postgraduate dean must give approval for a trainee to remain in the previous curriculum if they're not in their final year or covered by specialty specific exemptions, which I don't believe there are any for rheumatology. That's for those specialties new to training in internal medicine. And the transition status needs to be documented on the e-portfolio. What we are expecting is that educational supervisors should review the new curricular requirements with their trainees and identify any gaps that need to be addressed. There is guidance for that on the PTB website. I can share links after this. And there's also a gap analysis form on the ePortfolio that needs to be completed. As I said, all those who are transferring will have their ePortfolio accounts updated. There'll be no need to relink or transfer evidence. I think that's a big concern as well. That will happen when the trainee transitions to the new curricula. And again, that is a link to the latest guidance on our website, but I can circulate that separately so that people have those documents to hand. And that is me.
Thank you very much, Wiki. And I think while people have time to sort of think about other questions in this thing, and I think we're going to have the trainee perspective, a recorded presentation from Anastasia next. So, and then we'll have a role play between a trainer and trainee. Then we could have the second Q&A this session.
So yes, just bear with me. I'm just going to share
No problem.
Anastasia's pre-recorded session.
I think she's going to talk more about the gap analysis in detail and how she's gone through as a trainee with a trainer. Yeah, and I think you just get the audio for that.
Hello, everyone. My name is Anastasia Madenidou, and I'm one of the two SAC trainee representatives. Today, I'm going to share with you the trainee perspective, and just to clarify that I have pre-recorded my presentation because I'll be abroad on 8th of June, but I'm planning to be there for the Q&A session. Today, I'm going to tell you a bit of background why I'm doing this presentation, the differences between the old and the new curriculum from a trainee perspective, and I'll focus on transition and gap analysis. You will see during my presentation quite a few sentences in italics. This means that I copied and pasted these sentences from the guidance. And through the QR code, you can have direct access to the guidance or the new curriculum. So I'm an ST5 rheumatology and general medicine in Northwest. Currently, I'm doing only rheumatology at Salford Royal, but I did both rheumatology and general medicine as ST3 and ST4. This means that according to the new guidance, I need to transfer to the new curriculum. And my first reaction when I learned that I need to transfer to the new curriculum was not very good. I got very stressed. I thought that the new curriculum has to do with internal medicine trainees. So I was very disappointed because I thought I need to relink the evidence and I need to prove again that I'm competent enough. So what I did is that I emailed both the general medicine and rheumatology TPDs, and I asked them to stay on the old one. And my argument was that I have done 2 years of general medicine. I almost completed the GM competency, so I don't want to do things from scratch. And both of them rejected my request. As this was not an exception, my argument was not robust. And also, it's a GMC requirement for me to transfer to the new curriculum. And reflecting and looking back, and also having this role now, I'm happy to tell you that I overreacted, and the reality is more reassuring, and I hope to convince you today. Here you can see that trainees will not be required to relink or transfer evidence from the previous to the new one. And why does this happen? You know, with the old curriculum, we had to collect evidence for each presentation, and then our educational supervisor would say if we achieved or not this competence. With the new curriculum, we move away from tick boxing. Here you can see for general medicine, we now talk about SIPs, and we have these 8 SIPs, which means my interpretation is that these SIPs are the learning objectives that we need to meet by CCT. So we don't need now to collect evidence for its presentation. So I think the new curriculum is more trainee friendly, but it may be more challenging for the educational supervisors because now they need to write down how much they trust us according to the level descriptors. And now we move on to the transition to the new curriculum. And a crucial part is the gap analysis, which means that we need to find out the gaps between the new and the old curriculum. And here you can see that this gap analysis should take place at the start of the new training year between the education supervisor and the trainee. And the gap analysis should be recorded in a form which is called gap analysis form, which is already available in the e-portfolio accounts. You can get access to it by going to the educational supervisor's report, click create form, and then select group 1 specialty gap analysis form. And this is a screenshot for the form. And today I'm going to do my gap analysis with you. And again, just to clarify, I'm doing this not because I'm a role model trainee, but I have been in a lot of discussions and meetings about the new curriculum. So I think I have a good understanding. The first question in the gap analysis form is about clinical SIP 1, managing the acute unselected take. And it says here that trainees need to be entrusted to manage the acute take with indirect supervision. I think the majority of the trainees that have passed the GIM AICP will not have any problem here. In the General Medicine Educational Supervisor report, our supervisor needs to write down how we lead the acute medical take. And in my form, it says that the supervisor that I'm aware when to escalate complex problems to consultant. So I think this would be good evidence for my gap analysis meeting. The next question is about clinical SIP 4, managing patients in outpatient clinic, and we have to do at least 20 clinics outside rheumatology. And here you can see that I haven't done any clinics outside rheumatology, so I need to discuss this with my educational supervisor at the gap analysis meeting. And just to clarify that we need to do 20 clinics by CCT, not 20 clinics per year. The next question is about clinical SIP 7, delivering effective resuscitation and managing the acutely deteriorating patient. And here it says that trainees will be entrusted to act unsupervised by end of IM year 3. And again, I think the majority of trainees will not have any problem because of the old curriculum requirements. With old curriculum, we have to be signed off for the emergency presentations by GIM stage 1, which means end of SD4. So during my gap analysis meeting, I'm going to show to my supervisor that I'm signed off for all the emergency presentations, which means that I can manage a deteriorating patient. The next question is, will additional training time be required to achieve level 4 in all IM capabilities? Just to remind you, level 4 means to be independent. I think I can answer this question by going through the clinical SIPs, the 8 learning objectives. And as I told you before, I have no experience in managing patients in clinics outside rheumatology. However, I don't think I need more time in training. Then we move on to the specialty capabilities. The question now, have any training needs been identified for the trainee to meet the required level of entrustment and procedural competence for the stage of training? So here we have 2 questions. One is about the required level of entrustment. The next one is about procedures. Here is a screenshot of the new curriculum. And here you can see the 7 specialty SIPs. And for each SIP, we need to meet a different level of entrustment every year. And if you have a look at SIP number 4, I'm SD5 now, so I should be entrusted to act with direct supervision when managing transitional care. And I don't have any experience in transitional care, so I need to discuss this with my education supervisor. Here you can see the procedures, and I think the good thing with the new curriculum is that things are pretty clear in terms of mandatory and recommended procedures. As ST5, my only problem is that I don't have any experience in microscopy of synovial fluid, which is a recommended procedure. So I need to discuss this with my supervisor. And the last question in the gap analysis form is, will additional training time be required to achieve level 4 in all specialty capabilities? And I have showed you the specialty SIPs before. And going through them, as I told you before, there is lack of experience in managing transitional care. But other than that, I don't think I need more time in training. And now, just to summarize, I think I showed you how we move away from tick boxing, and now we talk about SIPs. It's very reassuring that we don't need to really link evidence. The evidence is there. Our education supervisor will review the evidence and decide on the level of entrustment. I hope I showed you that actually there are not many differences between the old and new curriculum. I do believe that gap analysis is very crucial. And as always, we need to work well with our educational supervisor to make sure we meet the learning objectives. And that's all from me. Thank you very much for your attention, and I'm happy to take any questions at the end of the presentations. Thank you.
Thank you, Anastasia, for the clear illustration of gap analysis and where you stand. And while you're waiting for the role play between the trainer and trainee being loaded up by Wiki, so there was a question by Nikita sort of asking who should do the gap analysis. And I think as Anne said, it should be the new educational supervisor in August 2022. And some people might be starting in September or October, their rotations. And again, we could start the new curriculum from October 2022. So these are some of the common questions which come on the transition.
Would you like me to share the next presentation now?
Yes, please.
Yep.
Yes, Vicky.
Okay.
Thank you.
Sorry. Apologies, I've got the whirring ball of unresponsiveness.
Okay. And now it's
it should hopefully take a second.
Okay.
Oh.
So Jenny, while we will try and sort of engage with the questions in the chat while we're trying to do so that we will save some time in the Q&A. I think Jenny has asked a good question. There are sort of a lot of people, only 20% of rheumatologists do GIM, and who should be sort of doing the things? And if you're not sure about the GIM capabilities in practice, so I think that's where having a GIM educational supervisor would be useful, at least a named one.
Shall I press play?
Yes, please.
Yep. Okay.
Thank you.
Thanks for coming along to this educational supervisor meeting. You've done your induction for Portsmouth, welcome. And we've discussed about your gap analysis. You've completed the form. So now I just really wanted us to have a look together at the new rheumatology curriculum, just to decide what's in it, what's new, what's the same, and what requirements you'll need to meet for the ARCP at the end of this year. Have you managed to have a look yourself?
Thank you. Yeah, I've had a look, and it's not as scary as I thought it was going to be, actually. I can see that they've already pulled over my old workplace-based assessments from the old portfolio, and I've started having a look at the new curriculum as well on the JRC-PTB website, and actually I think it looks like an improvement on the old one. It seems a bit more translational, a bit more relevant, so hopefully it'll be less of a tick box exercise and more actually making sure that we're ready to become consultants by the end, hopefully.
Yeah, I absolutely agree. So because you've still got a couple of years to go, you're ST5 and you're just entering ST6, you and the majority of rheumatology trainees in the country will be transferring to this new curriculum. I think it sounds scarier than it really is, because actually when you read the document on the JRC PTB website, it's pretty self-explanatory, and it's also quite exciting to be judged more professionally on your capabilities in practice rather than on the number of workplace-based assessments you've done. That felt a little bit more robotic, didn't it? Whereas now your educational supervisor, based on evidence from your colleagues, workplace-based assessments and other things, they're going to actually make a professional judgment about you in a number of different areas. There are 7, I think, capabilities in practice in rheumatology. So they're going to be looking at the end of the year to decide what level of entrustment you have. Do you know much about what the entrustment levels are?
I've had a little look at them, and it sounds like it's just the scale of the 1 to 4. So at the start, it's pretty much that you're observing, and then by the time you get up to 4, you're fully independent. And from when I looked at the curriculum, there was an online grid which showed the entrustment levels for the end of each training year. So I'm just in ST6 now, so I think by the end of this year, they want me to be fully independent in some of them, whereas others I'll still have a little bit more time. So I think I just need to go through and try to work out where I am for each of the capabilities in practice, and then just it'll hopefully help me to target which bits I still need to work on as well. So hopefully it'll be a good structure to help me with my PDP for the year as well.
Yeah, absolutely. Yeah. So we'll be meeting at the end of the year, so that I can produce an educational supervisor's report for the ARCP, and then we'll be looking and deciding together what level of entrustment you're at, whether you're needing indirect or direct supervision, or whether you're fully autonomous, which hopefully you will be in everything by the time it comes to CCT in a couple of years. So we'll be still looking at the same workplace-based assessments that you're really familiar with. So the case-based discussion, mini CX, for medicine, Acat, a new one for us who are an outpatient-based specialty, and OPCAT. That's non-mandatory, but that will probably also be a good way of showing how you can run a rheumatology clinic independently. So there'll be all this usual stuff, patient survey, MSF, but it will just be looked at with a slightly different view. And so with the entrustment levels, that will then feed into your ARCP.
I was going to say the OPCATs look, I know they're not mandatory, but they look quite good actually, because on the medicine side, I found the Acats quite helpful, and I think the OPCATs will probably be quite a good way of getting a bit of, I suppose, supervision that's more formal, because previously it's been quite difficult to get someone to come in and sit and observe you doing that many patients in a row, because it's quite good because they can feed back on your time management, as well as things like if you're getting flustered, if you're starting to run late. So I think it'd be useful exercise generally to do the OPCATs.
Yeah, I'm quite excited to do those. I think we should probably put a date in the diary and try one out, shouldn't we? So I thought what we'd do then, just as an example, we'd look firstly at one of the clinical SIPs, capabilities in practice, from the rheumatology curriculum. Yeah. You'll have a separate IMT supervisor that will look at that curriculum, but we'll just look at one of them, and you can just let me know where you're at with that and what kind of evidence you've got so far that would help decide what entrustment level you'd be. Yeah. Looking at the curriculum then, so one of the SIPs is Rheumatology Emergencies, and actually, Emily, by the end of this year, you should aim to be fully independent in this, be able to manage all of rheumatology emergencies. You can find them in the online curriculum independently. So how have you got on so far with those? Have you got any evidence to show how autonomous you are?
I think so far I've got a few good ones. So I mean, GCA and septic arthritis, I've definitely got mini KEXs, CBDs, a bit of audit work around those topics.
Yes.
I've not sort of personally managed a scleroderma renal crisis, so I'll have to try and manage one of those this year. But I've definitely got reflective practice and other things to the other emergencies I've seen, and as well we've got the rapid access clinics, I've got a logbook of all of the rapid access clinics that I've been to and have run. So, I mean, that's really good opportunities to manage acutely unwell and rheumatology patients, and I've done quite a lot of those. So hopefully, if I put my logbook on for those, you know, anonymised, then that'll be a good evidence that I've managed a lot of urgent rheumatology patients.
Well, look, you're almost there, and you'll get much more experience, I think, in Portsmouth because of our rapid access clinics, and also the on-call system as well. Out of hours, you're on call for rheumatology, so you'll definitely see a fair breadth of different rheumatological emergencies. I'm pretty confident then that you're going to meet level 4 by the end of this year. So there are plenty of others in the clinical document on the JRCTB website. There's 7 altogether, and it's probably worth just familiarising yourselves with those so that you know where you're headed. And there's also some generic capabilities in practice, or SIPs, as well. Have you had a chance to have a look at those? There are 6 of them.
Yeah, I have. I wanted to ask you, there was one of them I wasn't sure about if the evidence I've got so far was the right sort of thing. The ability to function successfully in the NHS organisation and management systems.
Yes.
I mean, I've attended M&Ms and I've got a presentation already in my portfolio. And as well, I've been on a couple of management and leadership courses, so I've got certificates from those. So I'm assuming that those sorts of things are the sort of evidence that they'd be looking for those.
Yeah, definitely. So with these, it's not about entrustment levels. It's about whether you are meeting expectations for your stage of training. So we don't need to worry too much about levels 1 to 4. Yeah, so certificates from management courses and all of that's very good. You'll get an opportunity in Portsmouth this year to maybe manage the SPR rota or organise the postgraduate meetings. That would feed into it. And also, I think you've got a national role, haven't you?
Yeah, I'm on the BSR trainee committee as well. So I don't know if I get a certificate from that. But if we don't have certificates, then can you put down sort of emails to acknowledge the role, sort of a confirmation that you've been given the role, those sorts of things?
Yeah, sure. I mean, if you write to the course leader and get them to confirm you've been on the course, or somebody to confirm that you've taken up a position of responsibility on a national level, anything like that will be classed as evidence, basically.
Okay,
End of placement reports, that sort of thing. Yeah. Okay. So it sounds like you've got a fairly good grip on what SIPs or capabilities in practice are.
Yeah, I think so. I had a good read through the curriculum.
Yeah, okay. And then did you notice any other changes? There are the 20 medical clinics, which is new. They're to be done in a specialty other than our parent one, so not rheumatology clinics, but something else, cardiology, respiratory, whatever. It's probably a good thing, particularly as we manage such multi-system disorders. Have you got anything that you particularly feel you'd like to learn more about?
I'm interested in doing neuromuscular disease when I'm post CCT as a consultant. So I'd quite like to go to some of the neuromuscular clinics. I know that there's some areas in the UK that have rheumatology ones, but more locally, I know that the neurologists can be quite happy to help as well. So I'll probably look into trying to do that. And then some of our ILD rheumatology ones, I think would be good experience to get, because you get such a crossover with ILD and dermatology as well with the myositis. So I'll probably try to those.
And don't forget the pulmonary hypertension clinic, Emily. You're very welcome to come along to any of those, which I do.
Thank you. I will.
So that's great. Pro rata, of course, you've only got a couple of years left, so that will be just 10 clinics over the couple of years. So aim to do about 5 this year. I think that's reasonable. So looking at elsewhere in the curriculum, you still have got the mandatory joint injections and soft tissue injections, and then there's some desirable interventions like nail fold, capillaroscopy and ultrasound. So that's not mandatory, but we do have a lot of expertise in ultrasound in Portsmouth. So that might be another thing to put on your PDP, musculoskeletal ultrasound and also temporal artery.
Yeah, I've done quite a lot of joint injection clinics, and again, I've got a log of the procedures I've done and the clinics that I've run. But ultrasound is something, particularly during COVID, where so much has been on the telephone. I've not been able to get the exposure that I was hoping to during my training. So hopefully, I can catch up on that this year. I know that some of the consultants are very pro teaching, so hopefully, I can monopolise on their enthusiasm.
Yeah, good idea.
There's BSR and ULA do ultrasound courses as well, so I'm gonna have a look into those.
Yeah. Okay, so it looks like we've made a good start on this new curriculum. Have you got any other questions? No?
I don't think so. I think looking through the curriculum, I think it makes sense. It's just that sort of the new process is always a bit scary to get into, but having actually looked at it, I think it'll be less bad than I initially thought. So I think it'll be fine. It's just taking it one step at a time. And I know that people have said that we're just going to sort of work through it together and get a lot of support. So I'm sure it'll be fine.
Yeah, absolutely. Well, I really look forward to working with you, Emily. Thanks very much for coming.
Thank you. I'll see you soon.
Bye.
Bye.
Thank you very much, Anne and Emily, for going through the curriculum in an interactive way and how a sort of trainee-trainer interaction should be. Okay, so I think we can sort of pause and try and take some of the questions on the chat that's coming through. Okay.
Yeah, so I've been looking at the rheumatology questions, Venkat.
Yes.
And there's been some comments about how the rheumatology experience may be negatively impacted by the increase in medicine.
Mm-hmm.
And I guess that's more a comment than anything, but I think we've tried to integrate the two, haven't we? Would you say?
Yeah, Ian has got a comment. Ian?
I was actually just scratching my head, but no, I think I think Anne's right. We've tried to integrate them. We've tried to make sure that the generic SIPs overlap, so that when people are doing their GIM, they're getting, they're getting training that is applicable. And we don't disagree that it will be a challenge, and it will need better planning of our training year.
Sure.
And more targeted. When you go to clinic, it's going to have to be targeted.
I think it's like when they're doing the rheumatology section of it, and then they're doing the GIM clinics. So when they are in the inpatient care, or they're attached to a rheumatology sort of other medical ward, then they can come and still do some rheumatology clinics. And then the acute unselected take is not going to be too onerous if you just think about at least one a month. Okay. And if they're doing sort of AMU, a period of 3 months will be counted, and the remaining 9 months they'll be available for rheumatology. So I think it's just planning, and I think the trainees need to take the initiative. And I think the local TPDs in rheumatology and GIM are having discussions, and it has to be sort of not one size fits all. It has to be adapted to the local region and what works for them locally. So I think still rheumatology will not lose out, and it's not a time limited training as we kept on telling. It's what capabilities you acquire and what is the time. So, and I think if again people think about unselected take as something you have to be doing out of hours, but if you think about sort of spending time 9 to 5 in the AMU for a period, then it's not going to affect your rheumatology clinics during the day. So you don't have to sort of take time off or nights or weekends and this thing. So I think that can be creatively sort of done. And I think it's not only rheumatology, lots of other specialists are trying to sort of do the internal medicine bit. So we'll have more people on the shop floor. And I think the workload and the intensity might go down, the intensity of medicine compared to what you're used to. So I think we need to see, because neurology and palliative care are coming on board, as well as GU medicine is. So I think it's not going to be too onerous, and I think we will have to review the situation as we sort of see how the sort of things evolve in every region.
Yeah, I think there were some concerns too about we're good at knowing our trainees in rheumatology where we see them so frequently, but with shift changes and personnel changes on the acute medicine floor, it might be more challenging for the educational supervisor to get a flavour of how the trainees are doing. I guess we just have to see how that goes.
That's right. With the current arrangements, I think they can't sort of see the trainees more. And again, Phil was mentioning about remote monitoring of trainees and this thing. So we'll have to try and sort of look at the model and see how it works. But probably if you've got too many trainees and too few supervisors, it can be challenging. And I think probably the GIM supervisors need to have more time.
Yeah. And regarding medicine, there isn't any mandatory ICU placement, is there? Although, of course, the deteriorating patient is one of the SIPs in the IMT curriculum. And then there's questions around what will count as a general medical clinic. So people have asked about combined clinics within rheumatology, and they've also asked about MDTs. I don't think either of those count, do they?
No, I think we passed that. Yeah. Yes, Ian.
Yeah, I was going to comment on that. No, it's specifically clinics outside of your specialty. So we did try and see whether or not joint clinics with renal or chest physicians could be counted, but no was the answer. I think there was a comment around sitting in. This isn't sitting in clinics, this is doing clinics. So actually, going, seeing patients and, participating in clinics, making decisions outside of your specialty, not just sitting and observing. There is some flex in that if you are 15 months from finishing and, you're not going to necessarily have to cram in 20 clinics in a different specialty. We can have some sensible pragmatism. It's meant to be 5 clinics roughly per year of training. So, I think cramming if you're transitioning, cramming 20 clinics into that final year just is daft, and we need a little bit of pragmatism to this. So it's not sitting in, it's doing, but it has to be outside of the specialty.
Yeah, and other clinics, so with non-medical specialties, they're not mandated at all. It's kind of up to you to go to orthopedic clinics or pain clinics or whatever else, isn't it?
Can I suggest when people are attached to wards, it's often quite useful to whichever consultant you're under, whichever ward you're working on, the consultants will almost always have a clinic that they run, and you'll be working with that team, with that consultant and secretary for a chunk of time. So ask to get involved with those clinics. It's what I've done in my mixed years so far, and it's worked really well. I've already got over 20 medicine clinics that would count, despite what my role play said.
Sure.
So one of
And
the
it's
trainee.
pro rata. Yeah, it's pro rata again. If somebody's got only 1 year to 2 years to finish in the new curriculum, they're not expected to do 20 clinics. They might just get away with 10 clinics. And I think it's just sort of taking that effort. And I think it needs a bit of organizing, as Emily was mentioning. So you need to know the specialty and see how they work, and then there's sort of transition. Because if you sort of every month you go to a different specialty, it might be difficult. But as if you're attached to a team, then it might be easier to see how they work and what's available, and then to try and plan that. So probably the initial one, you might be sort of observing their working or what they want, but you can sort of see a few patients, and then to working on and sticking to the same specialty will be helpful rather than sort of in the organizational way. And locally, we've been asked very renal team to try and sort of come into rheumatology because it works both ways. Some of the other specialties, they have to come and do rheumatology clinics. So we need to be prepared as rheumatology trainers in this thing to try and accept trainees. So our trainees can go to other specialties.
Great.
Venkat, there was.
Yeah.
I was going to say there was a question around whether ambulatory care type settings would count.
Yes.
I think there has been agreement that some can count, but there would be a discouragement from doing all 20, as ambulatory care, because it is meant to be a focus on outpatient care, whereas ambulatory care often is at that interface. So yes, some could count, but we would discourage all 20 being the ones that are counted.
It's also a good idea to try to attend things like pleural procedure clinics and the gastro clinics where they're acidic drained, because that will help you with your sign-offs from a trainee perspective. So they're very good because you get the benefit of getting your sign-offs for the procedures you have to do, DOPSs, good supervision, and also as in a non-rheumatology clinic. So use those opportunities.
There are some questions about requirements for the inpatient medicine. Are you able to signpost people for that? What are they required to do for their medicine?
I think it's, as Phil mentioned in his talk in this thing, and I think it's just what we're expecting the trainees. If they are continuity of care, there is no stipulated inpatient medicine requirements as such. But as long as you can manage chronic medical inpatients, because medicine people just mean as acute unselected take or AMU. And as he mentioned, it's sort of chronic long-term conditions outside rheumatology. So if you're attached to a medical ward, for example, a geriatric ward or something, and you get a flavor of what's happening there, and then to try and see what the geriatric registrars or other medical registrars are doing. Because in rheumatology, we don't have a ward as such. Okay, so we moved into an outpatient specialty or daycare specialty. So it is similar to the rota in this thing. So while you're attached to an inpatient ward for 6 months, you could still come and do rheumatology clinics or your injection clinic or something. But then again, you could try and have your acute unselected take around that time and try and sort of do that. So you don't have to spend all your time in the ward. But I think doing some ward rounds and taking some responsibility so that you get some continuity of care and understand following up patients. I think that is the spirit of the curriculum. And I think that's what we need. That's why they're not stipulating any numbers or anything else, number of ward rounds in this thing. So what is available locally, because it might differ from hospital to hospital and specialty what you're in.
And there's a bit of guidance on the IMT curriculum as well. There's questions around whether you need 2 educational supervisors if you're doing medicine and rheumatology.
Yes, I think so. I think that's what we would try and do, unless there's a rheumatology consultant in some places where they're doing GIM and they're familiar with the GIM curriculum, they're doing acute take, then possibly they could have the same person. But otherwise, to have 2 separate supervisors.
And would they need 2 ES reports for their ARCP?
Yes, one for the IM, because they're going to have 2 ES person, because if the ARCP is only run by the rheumatology panel in this thing, and they may not be able to sort of look at the IM competency. So they have somebody who's familiar with the GIM curriculum. So they would have 2 separate ES reports.
And that's similar to dual accrediting trainees now. They get 2 ES, they get 2 ARCP panels and outcomes.
And then going back, I'm afraid, to the outpatient clinics, people asking, you need to record it on your e-portfolio, obviously, somewhere. And also, do they cancel their rheumatology clinics to go to these GIM clinics? I guess there could be a reciprocal arrangement where perhaps you and the respiratory trainee decide that
swap.
You do a swap, something like that. It probably needs to be worked out locally, doesn't it?
That's right. So we can only give general guidelines and got specific ones. And I think we won't be able to timetable into your placements and other things. So I think some trainees who've taken the initiative have started doing it now. And if you sort of start planning it, it's not all at one go, but I think it'll take some time. So once you settle in your new job and look at what opportunities are available, and then swap with you, because you're going to work with your other medical registrars on call. So talk to them and then say you could sort of have a sort of a buddy system, which will work. You already got a room, you have a supervisor, and then that might be the same thing. That might help.
It may well be that if you're doing 3 months in another specialty doing ward work, that actually you do your non-specialty clinics at that time. But it like Venkat says, it's going to need to be locally negotiated, and we hope that there'll be a reciprocal arrangement. So all medical trainees are going to have to do 20 clinics outside of their specialty. So we're going to get people coming the other way, particularly as we're an outpatient-based specialty.
I think that's more or less all the questions, actually.
Yeah. Anastasia had a point. She raised her hand. Yeah.
Yeah, thank you. I just wanted to say, because it's all about planning to make sure we get the appropriate exposure, maybe the trainees would like to approach the new educational supervisors earlier, because we need to do this gap analysis and everything in August, but maybe planning things, after the ARCP would be advisable. This is, my perspective. looking through all the forms. And I don't know what's your, your opinion about this.
We've got a couple of
Thank
questions
you.
on transition in this thing, and Wiki is on the call. So, Wiki, there was one question about a trainee going out at ST6, and we tried to answer it at the out of program. And when they come back out of program after 3 years, where they should be on the old or new curriculum. This is a tricky transition question.
I would imagine if they're ST6, they're going to have to transition because
Yeah.
they're not in their final year. And I think they could apply to their dean if they didn't think so. But I think also that's 3 years down the line. That's quite a long
Yes.
time. I think the GMs,
Sure.
that curriculum's going to be very out of date. So I would imagine it'll
Yeah.
be in everyone's interest
Sure.
to transition.
Sure. An exceptional circumstance, and that's one of the reasons we don't allow people to go out of program in the final year, because that can sort of change things in this thing. But if there are any other questions on transition or e-portfolio issues or something, you can sort of refer to the frequently asked questions section, which is sort of constantly being updated. And
Or
I think
send any specific questions, because I understand that transition is obviously very personal to each trainee and it's very hard to answer in real generic terms. But we have a curriculum inbox, which is just curriculum@jrcptb.org.uk. So anything can be sent there and we can try and assist.
That's very useful, Vicky. That's very useful. So if any trainees were missed in this thing, and you can sort of address that in this thing, if you can't. Okay. Are there any other final questions before we wrap up the session?
No, I can't see anything new. Just
okay.
Just the same things we've already been talking about. And of
Sure.
course, this will all be available for people to look back on, won't
Yeah,
it?
yeah.
It will be posted on the JRCPTB website.
Yes, it's been recorded, so I'll get that up
Sure.
as soon as I can.
Okay, and then we will talk to the BSR and see whether they can have it for the trainees as well to access in the BSR website. But I think one of the places it should be available. One of the questions is about, so one of the comments is 1 AU2 every month, all through the training. And I think it will be different in different places. So this is the minimal requirement, and it can be done in 6 months, or it can be done throughout a year. And some places are doing it every 3 months, 3 months every year. So I think whatever suits and what works for that, because the GIM leads in every region and every trust are sort of trying to sort of plan these rotas for August. Okay, so we've got a surplus of trainees. Usually we've got gaps in the rotas. Now we've got more trainees trying to do the on-call. It'll be interesting to try and see. I think we've covered most of the questions in this thing, and I think the themes have been sort of done. And thanks for Anne for monitoring all the chat from the beginning. We're all talking. And I think to wrap up, thank you all for all the speakers today. Phil for devoting his time, Ian, Anne and Emily to prepare the role play, and Anastasia for recording a presentation in advance, and Vicky for a presentation as well as running the show despite one or two technical glitches in this thing and keeping us to time. And thank you all for engaging on a Wednesday afternoon, all the trainees and trainers. And the people can go back to things in this thing, and we couldn't sort of comprehensively cover everything in sort of a short time. But I think if there are any other questions or something, you can sort of talk to your TPDs, and then it will come up to the SAC, and we're going to discuss this in our regular SAC meetings. We will have a curriculum section, and I think we will try and address some of the queries and monitor how the curriculum is being implemented in different regions, and we will update things. So it'll be a two-way, and you've got all your trainee reps in every region, and you can sort of contact Anastasia or Emily to the BSR or the SAC, and that will be useful. Thank you all very much and wish you a good afternoon.
Thank you.
Thank you.